diabetes. So insulin secretory defect is very high in Indian patients. This is the point I would like to highlight over here. We know that diabetes is a progressive disease. Down the line, when patient get diagnosed type 2 diabetes, almost patient will lose almost 50% of beta cell mass. Every yearly there will be 4 to 5% beta cell mass, and 10 years, 12 years down the line after that. This is the normal trend of the progression, and it is a natural progression. It can vary from the patient to patient. But in this natural history of progression, we have to target the HbA1c, we have to target the glycemic variability, we have to give the treatment according to the patient's needs and comorbidities and symptomatology, and we have to be a patient-oriented, patient-centric approach. If you see the guidelines also, they also mention that use the molecule which are beta cell friendly, concentrate on weight loss, give a cardio-renal protection. So within the light of guidelines, we are definitely hiding the insulin, and the inertia is not getting overcome as far as use of insulin is concerned in our day-to-day practice. So when we start insulin in our patients in day-to-day practice, we have almost 8 to 9 years will be over. So traditionally we treat with the diet, exercise for a couple of years, then we with metformin, then we add sulfonylureas as a second line of drug. Then we go for a triple drug combination. Again, couple of years will get progress, and by the time patients start insulin, it is almost 8 to 9 years over, right? And if you see the HbA1c, average HbA1c in all the studies like diet care, A1C achieve, present and improve, the average A1C in our country is almost 9% A1C, right? So it is 2% higher than the recommended target. So even in spite of such a good anti-diabetics and such a good variety of insulin available, this is the control state of our patients. So there are definitely myths about the and barriers about the use of insulin. Like when we're recommending insulin to the patient feels that this is the last treatment. This is the last treatment for my diabetes, and my disease is very high. My disease severity is very high, and if insulin started once in a lifetime, I may not be go to oral hypoglycemic agents. Insulin causes the renal problems. Insulin causes the thinning of bones, and all these are the myths and misconceptions in our day-to-day clinical practice, that we have to overcome all these things with good counseling, with good diabetic education. We have to sit across the table, and it has to be individualized definitely, and we can all the barriers can be overcome, though it is the injection of related anxiety, fear of weight gain, fear of hypoglycemia. Fear of weight gain can be definitely overcome with the use of metformin and SGLT2 inhibitor with the insulin. Injection anxiety can be overcome with the proper guidance to the patient, use of insulin pens like penless devices. Then the fear of hypoglycemia. Whenever we are starting insulin to the patient, always remember the counseling is the most important part. Then we have to explain the proper technique of insulin used to the patient. Number two, number three, we have to explain the importance of SMBG to all the patients. Every patient on insulin should have glucometer, and it should check the all 3 meals once in a day, and another day he can check the post meal and monitor blood sugar levels where the sugars are going. Fourth point, we have to explain to the patient the risk of hypoglycemia, how to identify hypoglycemia, and how to overcome the hypoglycemia actually. And these are the basic requirements whenever we are initiating insulin to our patient. So this is how we can get the confidence of the patient and overcome the inertia from the patient's point of view, from patient's prospect. So these are the important points. So these are the rationales of early insulin therapy. We know that the type 2 diabetes is characterized by the early progression, as already mentioned. The oral agents alter the decline. None of the oral agents alter the decline in the beta cell function. Poor glycemic control is an important driver for diabetic complications. Early initiation is physiologically intelligent, provides long-term health benefits in type 2 diabetic patients. Now, as I already mentioned, the advantages of early insulin, it gives rest to the beta cells. So, whenever blood glucose are very high at diagnosis, particularly high glucotoxicity, lipotoxicity, catabolic state, weight loss state, in that circumstances, for a couple of weeks, if we are using insulin, that will give rest to the beta cell function. Whatever beta cells are remaining, they can function in a proper way in the later life, and the requirement of oral hypoglycemic agent will be less in the subsequent life. There are studies. Insulin has got properties like the anti-inflammatory, antioxidant, anti-apoptotic effects actually, and it provides a long-term benefit protection to the end organ via the metabolic memory. So these are the clinical evidences of early insulin initiation in type 2 diabetes, which improves the gives sustained glycemic control over a period of up to 2 to 3 years actually. So one more thing, when we are adding the insulin to our patients, generally it has been seen in the clinical practice. After third drug or fourth drug, we are adding insulin to the patient. But the study says that adding fourth drug will not be helpful for the patient, because here you can see it will add on the HbA1c, or it will increase the HbA1c rather than it causing the reduction in HbA1c. But if you are adding insulin to the third as a fourth drug to the patient, like it reduces the HbA1c by almost 1.3% if we are adding the insulin to the treatment regime. Now coming to the clinical prospects, like now we have to counsel our patient. Insulin is not a last treatment actually. Many times in between we start insulin to the patients and then we stop, like during the state of pregnancy, during the patient, when the patient are in ICU, patient with infection like diabetes foot and all, we start insulin, then we stop insulin. During pre-operative we start insulin, and after surgery, after healing of the wound, we stop the insulin as well. So we have to give an examples to the patient so that the confidence in the patient will increase that insulin is not the last treatment. In the beginning also, and to reduce the glucotoxicity we can use. So this is the normal clinical prospects of to use to overcome the insulin inertia in our patients. Now, which are the insulins which are which can be used in the children's actually? So the types of insulins already have been discussed. The Techimer and Degludec can be used over if age group more than 1 year. Glargine can be used in the patient more than 2 years. Actrapid, Aspart, Lispro are useful more than 1 year. It is recommended to use more than 1 year. Lispro less than 2 years. Glulisine can be used more than 6 years. The rest of all the insulin can be used in the all adults, elderly, and pregnancy. In pregnancy, recently the Dechimer glargines are recommended, and all the Lispro, Aspart, they are also recommended in pregnancy. We can definitely. So these are the proper guidelines how to initiate the insulin in the patient. So here you can see ADA, there is slight difference in use of insulin in ADA and RSSDI. ADA says that before giving an insulin trial to the patient, you give trial of GLP-1 RA, right? So try GLP-1 RA, then you can go with the insulin. So whenever you are thinking of starting insulin to the patient, just give a fair trial of GLP-1 RA. So in this slide you can see the basal insulin, the choice of basal insulin should be based upon the patient specific considerations, and you can start the 0.1 to 0.2 unit per kg per day, or 10 units per day, and gradually you have to monitor fasting blood sugar levels, and you have to titrate the insulin in the patients actually. Every third day, it can be done every third day, or 10 to 20 units increment or reduction according to the patient blood glucose levels. So when we want to add the boluses to the patient, if blood sugar is uncontrolled and if post breakfast blood sugar is increasing, then we can add the boluses to the insulin regime actually. That is called as a basal plus regime. Only one shot of bolus can be given in the breakfast or any desired meal which shows the hyperglycemia. Or when the postprandial blood glucose are increasing further, then you can add two doses of the boluses to the patients actually, right? So this is all depends upon the patient's need. If you are using NPH, you can start with the NPH at the night. Then, if the further requirement increases, then you can split the NPH in twice. In that circumstances, the two-third dose can be given in the morning and one-third dose can be given in the evening. If we need to monitor the blood glucose levels, and if the further blood sugar levels are increases, then you can go with the basal and bolus regime according to the patient's need actually. So this is the regular insulin regimes what we are using in our day-to-day practice. RSSD says that insulin should be considered in all the patients failing to achieve the glycemic targets on the three agents. The three-step protocol involves the initiation, titration, and intensification is recommended in all the patients. So, in the initiation with once daily basal insulin or insulin daily premix. So, RSSDI guidelines they allowed basal as well as premixed insulin or co-formulation insulin or twice. So, RSSDI guidelines are more flexible and they are more practical for our patients. So, we can have the choice of insulin as the initiation of insulin, basal, premixed, or co-formulation insulin, whether it is either OD dose in the night or twice in the, twice in the day also can be used. It entirely depends upon the patient's age, clinical features, glucose profile, risk of potential risk of hypoglycemia, and the patient's preference actually. But the basal insulin regime may be preferred in or basal bolus can be preferred as in case of severe hyperglycemia to treat the diabetes and the life-threatening conditions like the diabetic foot and also RSDI recommends basal bolus regime in severely uncontrolled diabetes and the patients with the infections. So these are the guidelines. Here you can see if the HbA1c is less than 7%, we can go with the 0.1 unit or 0.2 unit per kg body weight. And if HbA1c is more than 8, we can go with the 0.2 to 0.3, slightly higher doses per kg body weight as a OD dose in the night. Again, monitor the blood sugar level, that is fasting. If fasting is not getting fallen and in the target, we can increase the 10% unit of the total daily dose after 3 days, again or twice in a week. And that's how we have to titrate the doses. Here, after starting insulin, RSSDI guidelines says that if the goals are not met, we can give a trial of GLP-1 RA in between along with the insulin actually. So this slight difference in the guidelines highlight over here. So here you can see the tabular form. If you are using the basal based regime, use basal insulin, then go for the basal plus regime. If required, then you can go with the basal bolus regime, right? This is the basal based regime. If you are using premixed insulin, you can use premixed insulin as a OD dose. Then you can further titrate to BD doses. They have also mentioned to use premixed insulin in 3 times in a day. And if at all you want to use, you can use the co-formulation like Rhizodec and all. So these are the clear-cut guidelines how to use insulin in the day-to-day clinical practice. So when we want to use the premixed insulin as an initiation, so when the difference in the postprandial is more than 54 milligram%, then premixed insulins are preferred over the basal insulins actually. Now, this is the point I would like to say. The conventional use of insulin, the premixed insulins was most prescribed insulin in Indian country, Indian cohort, and 74% patients are there on the premixed insulin. But why it is preferred? Because they have given some reasons because of perceived carbohydrate-rich dietary habits, perceived higher glycemic response to the caloric intake, the ambiguity over the superiority of the one insulin over another insulin, and close association between the PPG and the severity. Due to this reason, the premixed insulin were used in India to a great extent, and the most important thing is the cost effectiveness. Because last 10 decades, last decade, the use of basal insulin has increased by 56% as compared to the premix 42%, and this is the data from the landmark trial by Sanofi. So these are the indications of insulin intensification from the basal to the other regions when the dose of basal is increasing to zero point 0.5 unit per kg per day. If the targets are not met with the normal fasting, but the HbA1c is increasing and if the postprandial blood sugar levels are consistently high, then we have to use the bolus insulin to the patient. So this is the recommended insulin titration regime what we are daily following in our day-to-day clinical practice. So the shifting insulin prescription paradigm in India, the holistic glycemic control with the basal line. If we are controlling the basal insulin properly by fasting, the postprandial blood glucose levels definitely comes down, and the overall glycemic control will improve in 24 hours. So fixing fasting first is the recommendation, and this was the changes in the complications to use the analogs in day-to-day clinical practice as compared to conventional. The analog use helps to reduce the vascular complication by 11%, renal complication by 7%, ophthalmic complication by 5%, and cardiovascular mortality by 3%. So there are little advantages of using analogs in our day-to-day clinical practice. So the basal insulin is the preferred insulin as the initiation insulin in our day-to-day practice according to the IDF, RSSDI, AS, and ADA guidelines as well, right? So why the basal insulin is optimal choice for the initiation of insulin? Because it gives a holistic glycemic control in all the three parameters, HbA1c, fasting, and post-meal. It reduces the risk of hypoglycemia. Greater patient satisfaction is there. There is a flexibility of treatment, comparable A1C and PPG reduction with significant greater fasting reduction versus the premixed insulins, and there is a significant reduction in the risk of development of diabetes-related complication. So whenever we are starting insulin, what OHS should be continued and what OHS should be discontinued, just a single slide and then I'll finish. Metformin we can continue with all the regimes of insulin. Whenever you are using basal insulin, we can continue the sulfonylurea, there is no problem. TZDs, when we are adding boluses to the insulin regime, then we have to reduce the dose of sulfonylurea or we have to stop the use of sulfonylurea. So when the basal bolus regime, sulfonylurea should be out to avoid the risk of hypoglycemia. TZDs, you can cut down the dose by 50% or you can continue, depend upon the patient choice and risk of potential of edema or weight gain. AGI, DP4 inhibitor and SGLT2 inhibitor, GLP-1 RA, all it can be continued with all the regimes of the insulin actually. So we have to be cautious when you are using sulfonylurea with the insulin regimes and TZDs with the insulin regime to considering the weight gain potential. So timely initiation of insulin can prevent beta cell exhaustion and reduces the risk of complication. Adding the third OAD or beyond third OAD in type 2 diabetes may not be helpful for the good glycemic control, and the basal insulin significantly improves all glycemic parameters, that is fasting, HbA1c, and postprandial. The global guidelines recommends initiation of basal insulin. Thank you for the question.
Yeah, thank you very much, Dr. Hassan. The basic issue when initiating insulin comes from the patient. Being practicing physician and diabetologist, we want to start insulin early, but then the reluctance comes from the patient. In spite of detailed explanation regarding the complications, the patient might suffer from the hyperglycemia. So educating patient and giving some time regarding explaining the benefits of insulin will be the key factor while practicing and initiating early insulins. And at the same time, going on adding drugs in fear of okay, we might lose this patient or the patient will change the doctor. This also practice we need to change because this quite happens. Okay, patient comes to you with list of drugs and when asked why you are here, so he's told, okay, I was advised insulin, but I want tablet only. So the next consultant, he again adds on one more tablet and the things they continue. So I feel
Very valid point, sir. Very valid point.
educating
in
the
day-to-day
patients
life.
and being reluctant, what's the need if he requires insulin, it's insulin. Whether the patient comes to you, yes or no. That's all. Yes, thank you.
One quick question. Now there has been paradigm shift in management of diabetes, like MNC, from pancreatic drug to non-pancreatic drug. Now with the invention of newer insulin, like I think GLP-1 based therapy, now few companies they are combining insulin preparations with GLP-1 based therapy. Now the most important concern or the limiting factor with insulin is the weight gain. Weight gain. So I think can we say that combining these two drugs together, we can actually overcome the weight gain that happens with the conventional as well as analog insulin.
Definitely, sir. Definitely. That is the reason why we have to continue the metformin, SGLT2 inhibitors or GLP-1 RS whenever we are using the insulin, and we have to cut down the dose which like SUs and TZDs along with the insulin regime. Definitely, because if you see the guidelines, everybody is focusing on the weight loss, all the guidelines, and they're giving small targets of weight loss like 5%, 7%, 10% weight loss over a period of time, 8 years, 8 months or couple of years. So definitely the coming era will be of this regime which will give either weight neutrality or weight loss.
And another concept is regarding that stunning phenomena. Now, when there is a glucotoxicity, lipotoxicity, in that context, basically there occur conversion of beta cell into alpha cell. So I think there was involvement of one gene called as a FOXO, I guess its name is FOXO. So with that transition, actually, what happens thereafter actually early beta cell failure. So when you are early initiating the insulin,
Yes.
you are actually overcoming this situation. So you can maintain the normal glucose control with preservation of the pancreatic beta
Yes,
cells.
definitely. I can share in a minute a story. I have a patient when first visit he came with the 520 blood sugar level with high glucotoxicity and urine ketones were negative. I convinced that patient for the use of insulin and that patient took insulin for a month. Then gradually I have started reducing the dose of insulin. Then that patient was there on only on metformin for 1 year. And after that, that patient lost weight of 15 kgs and he was off medicines for 3 years. And then gradually he started medications actually. So this is the importance of use of insulin to reduce the glucotoxicity. And if you are judiciously using the molecules properly and if patients are compliant, definitely we can get the maximum benefits. Thank you very much for the question.
I request our chairpersons to kindly felicitate our.
Nila sir, please.
I request Dr. Shafi sir to kindly felicitate our chairperson.
नहीं इधर का सर चेयर पर
कैमरा कैसे बस दीपक अरे पटेल अब्दुल जब्बार
For our next section, it is on inhalational insulin and focusing on the innovational molecule and by the person himself, Dr. Sanjeev Durga sir. I request our chairperson, Dr. Ajay Rote sir and Dr. Mohammad Shafi sir to kindly share the session. I request Dr. Indurkar sir, who is consultant diabetologist at Diabetic Care Center and honorary diabetologist at Bajaj Mahavir and Orion Hospital, awarded as Lifetime Achievement in DCC 2024. He is the academic contributor faculty for PHFI and CCEBDM course since 2009, and sir has got many publications in his name, position statement for HYQ and paper on adult vaccination, etc. Sir has organized ex Maha RSSDI and Chad hostess DFSI and PSG conferences. So I request Dr. Ajay Rote sir to kindly introduce the topic.
Good morning, all of you, and welcome this to this wonderful session that would be taken by our Dr. Indurkar sir. The topic is on inhalational insulin. There has been a lot of discussion on inhalation insulin for quite some time, and now probably this month we'll be having available it in for our patients. There will be multiple questions associated with us. I hand over the session to Dr. Indurkar sir for discussion on this topic.
Thank you, chairpersons. I think last couple of lectures, our speakers talked of insulin, and one of the major barrier was prick or needle. And we are happy that December 25 or probably late November, we are expecting this wonder. Before going to that, I'll be touching just insulin in one sentence and then directly coming to inhalational insulin. We know that insulin is a century-old wonder, and my previous speakers have very aptly touched that how it has evolved and where and when it has reached. But in all this progress, one aspect continues to be common, and that is invasive route of administration of insulin. And you will all accept that in spite of so many discussions across us, across all of us, to initiate insulin is goose pimple for all of us. Because once we say insulin, there is a risk that patient may deny, patient may leave, or patient may not take it. And the consequences we all have seen across our clinics, because complications are going up and up, and the A1C target reaching percentage is going down. 2007, Pfizer came out with Exubera, 2006, and then it went off in 2007 for some reasons. But 2014, Mankind US developed it. It was approved later on, and from 2018, they were working a collaboration with Cipla. 2024, the DCGI approved it in India, and this month we are going to have this wonderful molecule. Let us look at it. What is Afrezza? It is a rapid-acting inhaled insulin indicated to improve glycemic control in adult patients with diabetes. This underline is very, very crucial. When I learned that this is coming, I was happy for my pediatric patients. But unfortunately, till date, in US, in India, the approval is only 18 years and above. In US, this month, the data was submitted for pediatric patients, and we are expecting approval by May 2026. So this is first caveat which I felt that we will probably not use it for our pediatric patients. And then it was formulated using technosphere technology, insulin adsorbed onto carrier particles, which is FDP and P, drug device combination, compact inhaler, pre-filled use cartridge. These are the 4 unit, 8 unit, 12 unit cartridges with different color, and the breathe powder delivery is the mode of delivery. This is really wonderful. I have seen the gadgets not yet used in clinical practice, but what it says is the technosphere, that is microparticles with water, when they are combined with this, and the outcome is technosphere insulin, and at this pH it remains there. Once it is inhaled, as it goes to lung and comes down to physiologic pH, from this inert carrier the insulin is released and it goes into blood vessels. What is technosphere insulin and fate of FDKP? We always know a excipient, a carrier, a inert chemical, when it is combined with any drug system or delivery, the most worrisome is what negative impact it is going to give to our patients. FDKP is a carrier for insulin. Tiny technosphere nanoparticles holds insulin powder. Inhalation of TI, that is technosphere insulin, you breathe in, particles land deep in the lung alveoli, rapid dissolve and insulin release, moist and at pH neutral environment at lung surface, it dissolves particles, releasing insulin to blood. FDKP enters bloodstream, filtered by kidneys and goes out unchanged. The key points are FDKP is only carrier. There is no accumulation in lungs or body. And based on the safety pharmacological finding of technosphere microparticles, it did not cause any treatment related safety concerns. So this is known as TI or technosphere insulin. Is it really going to work? Before I initiate its salient points, I would again stress that injection was the major worry for all of us society patients, that we cannot inject regularly, daily, multiple times. And right from the entry of Exubera somewhere in 2014, we were waiting for inhalational insulins, and now it has come. So let us look at the various available studies data with this. It is coded as TI, and let us look at these figures. TI demonstrates quicker onset versus other regular insulin analogs, closely resembles endogenous insulin. This is Afrezza, this is Lispro, this is again Afrezza, this is Lispro. So practically, if you look at figures, there is little difference. The conclusion for clinicians is that it probably works like a rapid or ultra rapid insulin. Then coming down to A1C reduction, this is technosphere insulin, this is placebo, there is a huge difference. This is PPG excursion, the lower is TI, that is technosphere, with placebo there is lot of exertion, and very important, hypo, which was discussed by my previous colleagues, and it has been clearly shown that all hypos and severe hypos are definitely more than placebo, but if you look at figures, they are not really that high. And when we compare further regarding clinical efficacy of this molecule in type 1 diabetes, this is baseline reduction with technosphere insulin, this is with aspart, the difference within non-inferiority margin as per statistical data. Hypoglycemia, with aspart, it is more severe, and the non-severe hypoglycemia. So this is another interesting difference and very important. We Dr. Bhosle quoted that body weight gain. Whenever we start insulin in a normal weight or obese type 2, we are always worried that he's going to gain weight, and effects on body weight was hardly 0.4 gain with TI versus 0.9 with aspart. And probably this is minus, this is not weight gain, this is weight loss, and this is weight gain. So the difference is 1.3 kg. So at least this study clearly suggests that this insulin is probably not leading to weight gain, which is a major worry with us. The first lecture we heard about CGMS, and then coming down to comparison with regular analog insulin, there is a significant time improvement in time in range. And if you look at time above range, it is better with technosphere. So these data suggest that this is better than aspart. And if you look at improvement in PPG related parameters, there is hardly any difference between Afrezza and aspart. Now, safety was another important part which we always talk about. This is inhaled insulin. Remember, this we don't inject or we don't swallow. So it goes through a huge pulmonary area which is of a size of a football ground. And probably when it starts acting, it is going to make lot of issues, injuries, or some effects as far as lungs are concerned. So cough as compared to placebo, it is 25.6, and as compared to non-placebo comparator, it is more. Then throat pain, headache, diarrhea, productive of fatigue, and nausea. So probably most concern was cough, which is going to make either withdraw the drug or hold for some times, and many times patients may not tolerate it. So what they did, they had a pooled data from day 1, week 1, week 8 and onwards. And here they have shown that 26.9 of Afrezza patients versus 5.2 comparator treated patients. 94% of cough episodes were characterized as intermittent or single defined episodes. Cough was generally mild, dry, occurred within 10 minutes of inhalation, was transient and declined with continued use. And this has been shown in this that it has declined because of Afrezza. Cough was the most common cause for discontinuation from clinical trials, and 2.8% of patients treated with this discontinued therapy because of cough in clinical trials. We all are going to use it from next month. Maybe our next Insulin Summit will have our own data and we'll discuss it, how far these side effects were going to affect the number of patients put on this particular molecule. This is pulmonary safety. All groups had small decline from baseline means FEV1. This difference was resolved by the follow-up at 4-week visits. So drop in FEV1 was the first concern, but this data shows that at the end of 4 weeks, it becomes lesser and lesser. As I told, Exubera was withdrawn because of lung malignancies in human, and that worry probably still lingers. What is going to happen with a long-term use? And this data, long-term safety with Afrezza, has been evaluated in a 2-year study. There is small change in FEV1 occurred early, remained non-progressive up to 2 years, and resolved when treatment was discontinued. So let us keep a watch in our future patients when we are going to initiate this. Now the most important point is, probably we have to again go back to pulmonology, try to learn lung function test. And here FEV1, that is forced expiratory volume at 1 second, would be the deciding criteria whether we can put these patients on Afrezza. We'll discuss it subsequently. And here, 1 out of 3 individuals had small FEV1 decline. This is the bar which are showing with compared to TI is technosphere insulin and this is a placebo. Now, once we go ahead and try to look what are the issues of technosphere insulin and special populations. Diabetes mellitus along with no specific data on renal impairment used in individuals with renal impairment, frequent glucose monitoring and a lower dosage of insulin may be necessary. Secondly, pregnancy, limited available data with technosphere insulin used in pregnant women and are insufficient to determine drug-associated risk in this situation. Geriatrics, no overall differences were seen observed between patients 65 years of age and older and younger adults in clinical studies. Hepatic impairment, no specific data. There are no data on the presence of T1 in human milk, the effects on the breastfed infant or the effects of milk production. And as I said, it is not approved below age 18. Now let us look at it, what it is, how we are going to use it, and what are the various steps. The marketing people from that company will be visiting you. They are going to set up a small lung function test equipment with you. And unless and until you do FEV1 and it is more than 70%, then only we are going to think of starting this insulin to our patients. So route of administration, oral inhalation. These are the single cartridges, 4 unit, 8 unit, 12 unit. Recommended starting dose for patients need to insulin is from 4 units and gradually you can up titrate depending on patient's postprandial or 1 to 4 hours blood glucose, that is predominantly meal time. This is a meal time insulin. Remember when we are going to start Afrizam, there would be a long acting drug like degludec or glargine, or if the patient is on OHA, it will be on some OHA and you are going to tackle only postprandial peaks with this insulin. Other way, probably it's not going to work. The key considerations is that the bioavailability of insulin technosphere is 30 to 40% compared to injectable insulin. And what dose is written on the cartridge here is that bioequivalent dose. That's what they have mentioned in the literature. Dose labeled in each cartridge indicates that the bioavailable insulin when administered appropriately. That's what I said. Pivotal clinical study in type 1 diabetic patients already on rapid acting and switch post randomization to T1 who followed the dosing recommendations demonstrated lesser hypoglycemic risk with Afrizam as compared to subcutaneous insulin. So these are there would be pack of 10 of 4 units, 8 units, 12 units. Remove a blister card from package, put it in this small cartridge holder that is loading. It has to be inhaled and then once the cartridge is used completely, you have to reduce it. Afrija cartridge left over in an open strip must be used within 3 days. Now, as I again saying that FEV1 has to be more than 70%. Otherwise, it won't work, it won't help. So indications are TI is a rapid acting inhaled insulin indicated to improve glycemic control in adult patients with diabetes. Limitations would be in patients with type 1 must use with a long acting insulin, not recommended in diabetic ketoacidosis and probably all other acute stages, not recommended in patients who smoke, and probably beyond this, I would like to pollution is a big driver. Maybe in another year or two, we'll have passive smoking, pollution affecting lungs. And once we do FEV1 in our clinics, maybe many non-smokers would have less than 70% of FEV1. And I don't think there is any data available in polluted cities, polluted countries where we are or we will be using this particular molecule. Contraindications very clear. Now you have picked up that 70% FEV1 is must. So chronic lung disease such as asthma, COPD because of risk of acute bronchospasm during episodes of hypoglycemia you cannot, and hypersensitivity to regular human insulin or any other excipients. Before initiating, now let us come down. This is what I was saying. Smoking status. I think along with this pollution and related issues which are probably pertaining to our area, those available 4, 8 and 12, you can give in only this kind of dose. So if you are going to give 16, you have to use 12 plus 4 or 8 plus 8, like that. Not in use refrigerated store. These are foil packages. There would be 10 in one cartridge box. They should be used within 1 month. In room temperature, they must finish within 10 days. Strips must be used, opened within 3 days. Before use, cartridges and inhaler should be at room temperature for 10 minutes. So there are a lot of caveats before we use this. But it's a new innovation which would be probably useful to some of our patients. Why some, I'll tell it afterwards as a last statement. So things to remember before initiating, it is necessary to perform a detailed medical history, mainly pertaining to lungs, examination, assess FEV1 to identify potential lung disease. FEV1 should be more or equal to 70%. Assess it at baseline, follow every 6 months and annually thereafter to keep a watch on lung function, symptoms, and patients taking TI, that is technosphere insulin, FEV1 is likely to decline by about 20% from baseline. And if it declines, doesn't reverse, you have to discontinue the treatment. So lastly, it is the only inhaled insulin available in our planet. Ultra rapid acting mid-time insulin along with compact inhaler device. Oral inhalation of regular human insulin for prandial. It's not long acting, it is going to tackle only postprandial glucoses. Found safe and effective in clinical trials with over 3,000 treated patients. Offers proven mid-time glucose control, prompt reduction of high blood glucose within 20 minutes. The most common issues are hypo, cough, throat pain, or irritation. It is approved by India. So what I dream is once we get Icodec once a week long acting, so use it once a week and top it up with this preprandial inhalational insulin, which will decrease the pricks with a very huge percentage or number. And before I thank you, can you predict some of us what would be the cost of these 10 cartridges? Because that is the crux of therapy. If it is too expensive, majority of our patients will not accept it. If it is economical, yes, probably we will have it. So before I conclude, I thank organizers, thank my chairpersons, all of you to be with us on Sunday. And half a minute, you can predict what would be the cost, and then I'll close for discussion. Thank you very much.
How many units will be there?
This 4 unit, 8 unit, 12 unit, 10 cartridges will be both there in one package. Inhaler will be
Of each.
yeah, each. 10 cartridges of 4 unit.
3 to 4,000
Uh,
per month.
It is not yet announced, but they say practically 10,000 rupees per month. एवढंच सांगण्यात आलेलं आहे. There are no details. I think anytime they will declare this.
Again, as you said, I think excellent presentation first of all. So I think many patients they are taking basal bolus therapy
Right.
quite often, and they are reluctant to continue with the basal
Absolutely.
bolus therapy or multiple daily injection. No patient is willing to
Correct.
take. So in that context, actually, if I am interested to start with Apriza, So is there any formula for starting it? I mean, like suppose if my patient is taking 6 unit prandial insulin and he is taking 20 unit basal insulin at a time. So is there any formula
No.
to convert, or is it 1 to 1 unit we have to consider?
Theoretically, yes, but we cannot extrapolate to long acting.
No,
So-
I'm talking of prandial insulin.
Yes, they are saying that if your patients are taking unit to unit, usually we do conformation
Correct.
analog.
Correct.
But in these circumstances, 20% higher dose.
Exactly, because it is inhaled.
Yes.
Yes.
Bioavailability is less as compared
Yeah,
to injectable.
that was the major worry,
Yes.
why we are not
That will
getting.
again one of the negative factors. for
Yes,
nowadays.
yes.
So another thing is regarding, you said 10,000 rupees per month is enough. But what about actually, see, there are different patients, they are having different requirement. If somebody is having requirement to the tune of less than 20-30 units, it's fair enough to say 10,000 rupees.
Exactly.
But if somebody who is having insulin requirement of maybe hundreds of units,
He
we
can't.
have that kind of patient. So what about that kind of
I
patient?
don't think it. Again, when it comes to countries where the patient has to buy the drug, our patients will say we can't buy. So we have GLP-1 agonist, we have icodec line, we have Afrizza. All these are expensive, innovative drugs. So those who can afford, they should use it. For rest of the patients, we have other, yes.
So related to this, like maximum dose that is available is 12 units. So if a patient is requiring at one like for meal time, the normal dose requirement is say 24 units.
Yeah.
So can two post
Yes,
units?
yes.
But does it impair lung function faster?
We don't have that data. I think we'll get it subsequently. This is just a beginning.
And the maximum 2 years the data.
No, but it is likely that if you are doing it,
Oh, yeah, absolutely.
there are more chances that
Because alveoli are so sensitive for every insert.
Right.
And in our country where pollution is rampant,
yes.
this would probably deteriorate lung functions very early, rapidly, and we don't know after 4 years, this can go back from our country.
Only FV1 is to be monitored. nothing
Only
else.
FV1.
That is
the-
something surprising.
For that, the Cipla people are going to keep the machines with most of us.
Because for asthma patients, we monitor PEFR,
Exactly.
peak expiratory flow rate. And technically, the best measure of lung function is FEV1 upon FVC ratio.
Exactly,
Not
that
FV1.
they have mentioned in
Yes,
literature, so
yes.
that is the most appropriate way, but again, the call, are we going to? That is the second question.
Correct.
If not, probably this is enough, FEV1, but in coming couple of years, as it becomes available in all rest of the countries, we can have data. And I feel in another 3-4 years, it may be withdrawn from countries where there is rampant pollution. It
Yes.
may not work as per the data in US.
Exactly.
We did the clinical trials for Pfizer's Exubra in our hospital
Okay.
department. The main problem was actually the variability in the absorption. patient to patient
Right.
variability, Number one. Number two, they were not at all responding in COPD and
True,
asthmatic
true.
patients. That were the two reasons
Correct.
that malignancy came later on actually in
Right.
But there were the two reasons why it was withdrawn from market.
So FEV1 is a very basic criteria. We don't know the pathology or physiology of entire alveolar tree.
Any mitogenicity study conducted?
At least 2 years they don't, it must be in pipeline. If it is there, probably it is not disclosed, but FDA would require probably before giving clearance below age 18, which is expected by May 29, 26. The data is already given. They are analyzing it. We don't know, but it will be there on the web.
I would say it is a good option for some set of patients.
Definitely.
And it is one of the good tool for the in future. It might be useful in type 1 as they.
It is Tesla of our insulin. So it is a wonderful vehicle.
Major concern is related to the refrigeration of insulin. and
That
all
would be
they can
solved.
carry in the luggage.
Absorption, lung function, pollution, and the cost. These are the 4 problems.
Otherwise, there is none.
So let us hope we use it and meet again after 1 year. Sharma sir.
The only good thing is that this inhaled insulin, they have made such a good device.
Yes.
So that you don't have to train them, like suppose if you are training them to take inhaler, you have to, endless it is. उसको coordinate करो at the time inhalation like that. So it just
Same as that of rotahelers that were.
हाँ वैसे ही रहेगा. But look, all these procedures again going to affect the
Compliance.
literacy of patient and compliance.
Compliance.
In the busy clinical practice, giving FEV1 and giving that option of insulin to the patient with such a high cost and just for bolus replacement. I think this is not going to suffice all the purposes of
This is prick number reduction. Yes. Because our major worry is a needle.
Yes.
So it may help. And like semaglutide, which we have to take orally, get up in the morning, fasting, 1 glass of water, sit for 30 minutes. This is practically very difficult every morning. So maybe let us see. Yes, sir.
Sir, is there any data regarding acute upper respiratory tract?
उसमें नहीं देने का. Absolutely not.
So, and
During therapy, actually, patient develops that.
That data will get it now. There is nothing disclosed till today. I think, as I said, next year, all of us will have some short cases on this and we can share this. Thank you very much.
Sir, your
Thank you, sir.
proposal of
Yes, sir.
Icodec and sustenance is wonderful.
वो तो बढ़िया होगा. आइकोडेक के बाद शायद once a month भी long acting आएगा. By the time you and me retire.
Sir, thank you very much for such a nice talk. I just want one update,
Yes.
sir, regarding the oral insulin. I am very fond of oral insulin. When I teach epidemiology in my institute, I encourage students to go for developing oral insulin while we teach the clinical trial to compare between injectable insulin with
सही है.
oral. So, any update regarding oral
Actually,
insulin?
the issue with oral is once it is inside the GIT, it is destroyed by proteolytic enzymes. So the scientists are trying to coat insulin with some polymer where it will not be digested and it will be released after that. Similarly, rectal insulin was also thought of. There are many other, and insulin patches are also thought, but nothing is out yet. This is what we are listening since 6 months, and I hope we get it next week. Let us use it. Thank you very much.
I request our chairperson to kindly penetrate our speech. Oh, thank you. Thank you. ये आपको फेलिसिटेट करना पड़ेगा कि शफी सर I requested Dr. Deepak Sir to kindly felicitate our chairperson.
Moving to our next session, in hospital management of hyperglycemia, I call upon Dr. Tuba Fatima ma'am and Dr. Minal Muslim ma'am to kindly chair the session. Our next speaker is Dr. Deepak Bhosle sir, who is consultant and diabetologist at Devgiri Diabetes Center. Devgiri Diabetes Center, and sir has published around 60.
So I think we are running short of time, so we'll cut down the introduction and we'll directly go to the topic.
I request chairperson to kindly introduce the topic.
Good afternoon, everyone. Our next session addresses a critical aspect of inpatient care in hospital management of hyperglycemia. To guide us through evidence-based approaches and practical strategies for managing hyperglycemia in the hospital setting, I now invite our respected Dr. Deepak Bhosle sir to begin the session. Thank you.
After the excellent presentation by Indurga sir, so I'll be talking regarding I think a very unique topic or a very fascinating topic that is related to the in-hospital management of glucose. So I think I'll be talking it in two different sets. First would be treating diabetes in non-critical care setting, and second would be treating diabetes in critical care setting. So I think it's very common problem. If you see around one third of the patients who are getting hospitalized, they are having some or other form of hyperglycemia, maybe stress induced or maybe type 2 diabetes or maybe other form of hyperglycemia that need to be aggressively managed. So in my talk, actually, I'm just going to discuss regarding these three important questions. First is actually how important is glucose control in hospital. Second is actually what are the target that we must aim for. And third question is what are the best way to achieve this target. So my topic of discussion would be only these three questions. So as we know, around 38% of the people who are suffering from some or other form of hyperglycemia in day-to-day clinical practice that we see in critical care setting or non-critical care setting. Of that, 26% had known history of diabetes. I mean, non-diabetic patient, they are getting hospitalized for some or other reason. They are 26%. And other figure is 12% had no history of diabetes. They are either coming as a stress-induced hyperglycemia or newly detected diabetes. And if you see literature, you will find these 12% patient, they are having actually worst outcome in terms of actually ICU morbidity and mortality. Then why actually diabetes is to be addressed very efficiently in patients who are hospitalized? Because diabetes can cause longer hospital stay, higher admission rate to the ICU, then higher rate of infection, and most importantly, the cost involved in management of diabetes will also be very high. Then what is the definition of hyperglycemia in hospitalized patient? Any blood glucose level which is more than 140 milligram percent, you can label that patient as having hyperglycemia. So that is, I think, a very clear-cut definition given by American Diabetes Association and even endorsed by RSSDI. So hospital hyperglycemia more than 140 to what you are going to call as a stress hyperglycemia. That's the reason actually whenever any patient he or she is getting hospitalized, you need to check the HbA1c value. Why it is important? Any HbA1c which is less than 6.5, but patient's blood glucose level is more than 40, maybe 200, 300, 400, 500. We see quite a lot number of patients getting hospitalized with a blood glucose value of 300, 400, but their A1c falls less than 6.5%. So that is categorized as actually stress-induced hyperglycemia. And more of the time, actually, this stress-induced hyperglycemia can be managed by using insulin in hospital. And over the period of time, patient may be discharged with insulin oral drug or maybe with diet and exercise. And subsequently, by doing OGTT, they can be reclassified. And the third category is A1C more than 6.5%. Any patient getting hospitalized having A1C more than 6.5% is a newly detected diabetes. Now, what is actually hyperglycemia in hospitalized patient? I call it as a cat and mouse game. And remember, actually, here I call insulin as a cat and I call glucose rather than glucose. Actually, I will calling it as a rather than mouse. I will call them metabolic mice because apart from glucose, there are other hormones, other hormones and other cytokines which comes into act and they ultimately impair the insulin action and insulin secretion and leads to the severe kind of metabolic stress that ultimately end up with the hyperglycemia. And apart from that, Ehsan has already explained insulin has anti-inflammatory action, vasodilator action, antioxidant and anti-thrombotic property. So that's the reason actually insulin is very important. This is again a picture showing how blood glucose level with stress hormone, then over glucose production, reduced glucose uptake, increased free fatty acid, that will all will lead to the hemodynamic insult, then electrolyte losses, and there are so many other consequences that can happen in diabetic patient. So some data related to the ICU mortality in diabetic patients. So this is a 30-day mortality in hospital complication in diabetic and non-diabetic subject. I mean patient getting hospitalized for like maybe ARF, AMI, UTI, different kinds of comorbidities. And if you see the difference, no diabetes, you see bars are smaller, whereas diabetes bars are larger. So any patients who is having diabetes and develop any kind of comorbidity, risk of morbidity and mortality is very high. Then prevalence of hyperglycemia and critically ill patient is to the tune of almost 50%. And hyperglycemia is an independent marker of ICU mortality. And especially why I have shown this slide because of this thing. Because if you see any hyperglycemia which is new onset in critical care setting, it has mortality to a very higher percentage as compared to a patient who are either having existing diabetes or hyperglycemia. Then if you see this different actually cohorts of blood glucose level, as the blood glucose level in hospitalized patient is increasing over the period of time, the mortality goes increasing, and mortality also significantly goes high. Then this is, I think, very popular study conducted by Lyon in surgical ICU, where they have treated more than 1,500 patients with conventional insulin therapy and intensive insulin therapy, and their primary outcome was ICU mortality. Now, if you see the, if you see, if you see actually survival in ICU, you see that with the intensive therapy, there was reduction in mortality to the tune of 42%, and mortality has significantly gone down to the tune of 34% in hospitalized patient with the intensive therapy. So by and large, actually intensive therapy was excellent. As close to the normal blood glucose level you are maintaining, you are improving the ICU outcome. So this is regarding the why it is important to control the blood glucose in hospital. The second question is, what are the target that we must aim for? Now, as we have seen in case of the Lyon study, basically as close to normal blood glucose level you maintain, that much better outcome you will have in ICU patient. But unlike that Lyon study, there was another study published, which is a nice study, I think, which is the largest of the clinical trial conducted with intensive insulin therapy, which has shown actually the intensive insulin therapy has been associated with increased risk of hypoglycemia and increased mortality in critically ill patients. So again, that has created a problem. On the one side of the coin, we are saying that tight glucose control is improving the ICU mortality, and on the other side, big data is saying there is increased risk of hypoglycemia and increased mortality. Now, then there comes the question, where should we keep the target? Now, this is the target. Basically, this is actually the consensus algorithm by AACE and ADA, where perioperative period and ICU, the target is to be 140 to 180 milligram per cent. Now, why it is 140 to 180? Because we don't want to go too low. Because these all patients, they are critically ill patient, and they are actually likely to develop hypoglycemia, and single episode of hypoglycemia can be potentially fatal in such a patient. Then second is, hypoglycemia definition is 70 milligram per cent. Treatment threshold would be 180 milligram per cent. Any blood glucose level which goes more than 180, so I think you need to aggressively manage that. So these are the actually targets for perioperative period as well as ICU patient, 140 to 180. Now, if patient is stable in ward, what should be the target? Now, the 140 to 180, now here it becomes 100 to 180. Because as I told you, actually, those patients who are critically ill, there we are keeping target in between 140 to 80 to prevent the risk of hypoglycemia. But here target is 100 to 180. Then again, the treatment threshold would be pre-meal more than 140 and post-meal more than 180. Again, the definition of hypoglycemia will remain 70 milligram per cent, and hypoglycemia and severe hypoglycemia less than 40 milligram per cent. This is as said by the American Association of Clinical Endocrinology and ADA. Then third question is, what is the best way to achieve this target? Actually, we have learned what are the target that we must aim for. Now the third question, how to approach this. So I think we'll take one case study, and based upon that we will discuss a 53-year-old gentleman with type 2 diabetes getting hospitalized for cellulitis right foot, and is on IV antibiotics, is stable, eating well, and is on metformin 1 gram twice a day, taking glimepiride 1 milligram daily, weight is 80 kg, and FPS is 280 milligram per cent, HbA1c value is 7%, and he has leukocytosis. A1c 7%, suggesting that the patient is having good glucose control in the past. I think all of us are facing this kind of situation quite commonly in day-to-day clinical practice. Now, how to see this kind of approach, this kind of case in clinical practice? There are some steps that you need to follow. The first step is actually selection of the insulin regime. Which insulin regime is to be used? So I think the first one is the basal, then you can go for prandial insulin, you can go for premix insulin, you can go for basal bolus, and you can even go for intensified premix insulin therapy. So there are all kinds of permutation and combinations available here. You can start with basal, and all these kinds of regimes they can be used. Then second important thing is, out of this, which one is the best? Those patients who are stable and eating well in what, so I think the best one is the basal bolus therapy. Why basal bolus is best? Because it can achieve a quick glycemic control, it can be used in stable patient, and it is more physiological. So that is the reason I think this is I think more commonly accepted in ward patients. Then step 2 is selection of the dosage. So what are the dosage that you should use? So I think 0.3 units per kg body weight you can use in a patients who are emaciated, thin build, or having or elderly patient, or patient having stress-induced hyperglycemia. Then second is 0.5 unit per kg, so that you can use in normal build person, and 0.7 unit per kg you can use it in obese, overweight patient, or the patients who have been treated with steroid, severe sepsis, on insulin, and who are uncontrolled. So there you can use it to the tune of around 0.7%. And the current patient that we see, he falls in a category of normally built people, hence we are using 0.5 unit per kg. This is step 2. Step 3 is actually, again, second important thing is, there are different kinds of patients who are getting hospitalized. So based upon that also you can decide, like patient, if they are eating well, remember, you can divide basal and nutritional insulin to the basal to the tune of 40 to 50%, nutritional insulin to the tune of 50 to 60%. The patients who are meal per oral, there you can use only basal insulin, don't use any nutritional insulin. It can be used only as and when required, with strict monitoring. Then continuous rice tube feeding, only basal insulin can be given to the tune of 40 to 50% of total daily dose, and nutritional insulin can be divided into 3 to 4 divided doses. And the patients who are on high dose of systemic steroid, so I think there it is recommended to use both kind of insulin therapy, but I think those who are on high dose of systemic steroid, there it is recommended to use high dose of nutritional insulin as compared to the basal insulin. Then next step is related to the actually how to calculate the dose. Now there is one formula called as actually 4/12 rule. Now how to calculate this? Now you can see the basal replacement and prandial replacement, they can be calculated by two different formulas. Now the basal replacement, weight divided by 4. Like, see, the patient's weight is 60 kg, 60 divided by 4 is equal to 15 units. So it is a requirement of the patient. But how to calculate the prandial? Prandial, you have to divide weight by 12. So 60 is the weight, 60 divided by 12 comes 5 units before each bill. So 5, that is 15 units. So 15 plus 15, 30 units. So this is again 4/12 rule, another crude way of calculating the dose of patient. Then let us come back to the case of this 53-year-old gentleman who has been hospitalized for cellulitis. Now you see here, again its weight is 80 kg. So is the average build person. So 0.5 into 80 comes 40 units. So again, how you are going to divide the dose? So you can use any of the basal insulin like Largin, Datimir, or NPH to the tune of around 24%. And injection, short-acting insulin like Lispro, Aspart, or Glulysin 655. So this total comes around 40 units. So this is how you have to divide it: 50% basal and 50% short-acting insulin, divided into 3 different dosage. Then step 4 is how to adjust the insulin dose. So I think the most important thing, once if you start with the insulin therapy, how to adjust the dose based upon the SMBG. Now the most important thing is you have to evaluate the glucose pattern. You have to evaluate the glucose pattern, and if fasting blood glucose level is elevated, you are supposed to increase the total daily dose by 10 to 20%. 20% you have to increase the total daily dose, because fasting itself is high. If fasting is high, prandial is going to high. So that's the reason you have to increase the total daily dose of the patient. But if the fasting blood glucose level is in target, here you are supposed to increase only the dose of prandial insulin. Now, why it is important? Because see, fasting blood glucose level in normal range. If you increase the total daily dose, risk of hypoglycemia early morning will definitely increase. So that's the reason it is not recommended. You can increase only 10 to 20% of the basal insulin. Then another important thing is whenever we are giving basal bolus therapy, these are the three components that we are considering for insulin therapy. Basal, which covers the blood glucose level in between meal, nutritional component of the insulin that covers the meal component, and there is another component mentioned as a correction. Now, what is correction bolus? Now, correction is something given to a patient. Suppose take an example, this patient hospitalized in what? His blood glucose level you have checked in the afternoon before lunch. It came 300, but your target blood glucose level is 100. So he is having 200 milligram percent above the target. So how you are going to achieve that target? Because your job is to bring that 200 to 100 and again you cover to the lunch. So these two things that you are supposed to do parallelly. Now, this correction is nothing but actually the additional amount of insulin that you are going to add to the scheduled dose. So that is called as actually correction bolus. And I think this is the best approach to treat the patient. And mostly when nutritional component is combined with correction bolus, it is called as actually supplemental insulin. So that pattern you need to follow. Now how to understand the correction factor. Now correction factor, how to apply it basically that I will tell you. So this is rapid acting insulin. Correction factor is 1800 divided by total daily dose, means 1800 divided by 60, it comes 30, means 1 unit is going to reduce the blood glucose level by 30 milligram percent. Whereas when you are using analog insulin, it is 1500 divided by total daily dose. So it comes around 25, means 1 unit of analog is going to reduce the blood glucose level by 25 milligram percent. So this is again one scenario that I mentioned. The current blood glucose level of patient is 250. Your target blood glucose level is 100. Your glucose correction factor that you calculated is 30, means 250 minus 100 equal to divided by 30 equal to 5 units. Means whatever scheduled dose of insulin, suppose scheduled dose is 8 unit for covering the lunch. Apart from that, you add this 5 unit, so that in total you are going to give 13 units to cover the meal. Then this is again actually the same patient after using this basal bolus therapy. If fasting blood glucose level comes 160, increase the night dose and add some supplemental insulin to correct this 160 milligram percent. Then in the lunch time, basically it is 270 again, morning dose adjusted and give some additional insulin, so and so forth you have to do. And ultimately whatever additional correction amount of insulin that you are using for breakfast, lunch and dinner, that you subsequently add to the next day's dose. So that is what you are supposed to do. Then this is again a simple correction chart. Correction chart is not basically the sliding scale, because sliding scale I am going to discuss later on. So this is small correction chart like blood glucose level 90 to 130, give scheduled dose of insulin 70 to 90, reduce the dose by 2 to 4 units. This is again, you can have your own hospital algorithm for managing the hyperglycemia in hospitalized patient. A few words related to the sliding scale, which I think many clinicians still they are using in clinical practice. So this I think nothing but a just chart pasted in the ward or ICU. I mean, if this is the blood glucose level, give this much insulin. Now doing so by using sliding scale, we are treating the past. Remember, we are not supposed to treat the past, we have to treat the future. And when you are using sliding scale, it is more unphysiological, it is causing too much fluctuation in blood glucose level. And as I told you, it treats the past and it never takes into account the food timing. And remember, basal must even in eating. Now this is I think the roller coaster effect that you see with the use of sliding scale. That's the reason actually sliding scale should be obsolete, and one should use actually basal bolus plus correction in managing hyperglycemia in hospitalized patient. Now I just added one simple example to understand actually how sliding scale can be painful in critically ill patient. Now at 10 p.m. a patient getting hospitalized with the blood glucose level of 380. And remember, most of us are pasting this instruction to the nursing staff regarding administration of the insulin therapy in hospitalized patient. So for 380, the 24 units of insulin is to be taken as it is mentioned in the order. So it is given. But does sliding scale take into consideration that the patient just had his food? No, it is not going to. It is not taking into consideration. 6 a.m. blood. It is mentioned if blood glucose level is 70, don't give any insulin. But it is not again considering that the patient is going to take his breakfast. Then at 12 noon, again the blood glucose level is 311. Why it is 311? Because we have not given any insulin at this point of time. Then as it is a 311, in the 12 noon, 24 units of insulin was given and patient was, see again, patient going to eat and told to eat less. Why he was told to eat less? Because blood glucose level is on higher side. Then at 4 p.m. patient develops hypoglycemia, blood glucose level become 49, again no insulin, but because of hypoglycemia, patient can be bombarded with all kinds of sweet, maybe with candies, with sugars, with mango juices. So everything patient they will take. At 7 p.m. blood glucose level comes 100. But then onwards, basically it is mentioned with no insulin in sliding scale. But you see, sliding scale is again not considering that the patient is going to eat after a massive hypoglycemia. At 10 p.m. when blood glucose level was checked, it was 540. Again sliding scale, 36 units of insulin is pushed in. But again here it is not considering that the patient just had his food and 2 a.m. patient developed massive hypoglycemia with neuroglycopenia or seizure and all that. So I think this kind of problem that we see with the use of sliding scale. So this is the picture that I think you can match. It is causing too much variation in blood glucose level, and this too much variation in blood glucose level can be more detrimental for the vascular health in critically ill patients. So that's the reason actually you should avoid or discourage using the sliding scale, or you should use more and more basal bolus plus corrections. Now this is again a rabbit 2 study, rabbit 2 trial, which has studied basically sliding scale versus basal bolus, and definitely basal bolus does better as compared to sliding scale in terms of ICU mortality. This is again one of a very important study which has given us basis regarding use of sliding scale instead of use of basal bolus instead of using sliding scale. Now this is case 2 that we are going to see. A 68-year-old lady was admitted to hospital with urinary tract infection. She was asymptomatic and eating well. She was on premix insulin, taking 12 units in the morning and 10 units in the night, and suddenly she becomes dyspneic and on X-ray shows all sorts of patches, and she develops actually ARDS, aspiration pneumonia, and she has been shifted to ICU and she has been ventilated. Now glucometer reading comes 400. So I think this is quite common scenario. Those who are dealing with the critical care, this is quite common scenario for them. Patient from general ward getting shifted to the ICU with blood glucose level of 400 mg/cent. So how to manage hyperglycemia in such a scenario? It is insulin infusion basically. Now why it is important to use insulin infusion such a scenario? Because it is more flexible, safest and fastest way to achieve the glycemic control, where actually we are running 2 taps parallelly, where one tap is running with glucose and other tap with the insulin. This is how we try to maintain the euglycemia in a critically ill patients. Now, how to start with the insulin therapy in critically ill patient? Now, insulin infusion, actually 50 units of short-acting insulin is mixed with 50 ml of normal saline and divide glucose level 50 to decide actually bolus. To begin with, you have to give some bolus dose. So, you have to divide blood glucose level by 50 milligrams. So, that will give you an idea about giving the bolus dose. Now, here the blood glucose level is 400. Divided by 8, it comes around 8 unit basically. So straight away you have to push in 6 units of short acting insulin. Then how to continue with the drain? Then you divide the blood glucose level by 100. Blood glucose level is 400. So 400 divided by 100 is equal to 4. So you just continue with the 4 units per hour. So that rate you continue, and accordingly you go on monitoring the blood glucose level, and depending upon the values of blood glucose level, you can adjust the infusion rate. The target sugar, if it is in between 142 and 80, it's okay. Continue with the same. Monitor the blood glucose level, and accordingly you can change the rate of the infusion. Now, blood glucose level on target, more than 180, increase the rate. Less than 140, decrease the rate, and RBS in target range, continue with the same rate. Again, this is ICU setting. This is the insulin infusion. The default insulin drip column actually, which has been published in RSSDI guideline basically, and this is again one protocol that you can paste. At least nursing staff they can follow, or paramedic staff they can follow in managing hyperglycemia. Then IV fluid, normal saline rate depending upon the patient's condition or degree of dehydration, you can adjust. When RBS less than 110, changed normal saline to 5% to 10% dextrose, and if patient is in NPO and require calories 10% dextrose alone or in combination with normal saline is important, otherwise patient will end in phase of catabolism. Then hyperglycemia management in certain special conditions, especially actually a kidney or the CKD patients. I think it is very important to understand because kidney itself produces some basal insulin. So this basal insulin is responsible for giving cover to the fasting blood glucose level. So that part component will go up in patients of CKD. Then second is kidney produces insulinase, which degrades the insulin. Third, CKD patient, they have hyperkalemia, which can accentuate the insulin action. And fourth thing is actually the patients who are having CKD, they themselves actually become anorexic and don't eat any much, so blood glucose level will come automatically onto the normal range. And this is actually as good as you can call it as a burnt out diabetes. So these are factors basically, they are very important in management of hyperglycemia in patients of CKD. Then transition from IV insulin to subcutaneous insulin. So I think you need to calculate the total daily dose. Now patient's hourly infusion rate, while nilparolol is 2 units per hour. So 24 into 2 comes 48. But whatever extra amount of insulin that you have given as a part of stress that generated because of the illness, so that need to be actually subtracted. So 2/3 into 48 comes 32 units. So basal calculation comes around 32 units. So total daily dose is 32 into 2 equal to 64, and this you can divide into basal bolus, 50% basal and 50% bolus, which is again divided into 3 short acting breakfast, lunch, dinner. Then at the time of discharge, basically if A1C is less than 7%, restart the previous outpatient treatment which patient was taking in the past. Second is actually, this is where most of us are failing actually. That is what I observed in my last 22 years of clinical practice. Even patients were having admission A1C 7 to 9%. At least actually basal insulin is to be continued along with the oral anti-diabetic agent. And definitely any A1C more than 9%, I would suggest, especially in a patient who have undergone major surgery or major hospitalization. So I think there it is always prudent to continue with the basal bolus therapy for some days, and once the patient becomes metabolically stable, then you can actually think of switching patient to the oral anti-diabetic agent. The last part of my question is again, how important is glucose control in hospital? I think it is very important to control the blood glucose level. By controlling the blood glucose level, you can actually reduce the ICU mortality and morbidity. Then what are the target that we must aim for? So I think target, I told you, in critically ill patient 140 to 180 milligram percent, and those patients who are hospitalized in ward, it is 100 to 180 milligram percent. And I think what are the best way to achieve those targets is, I think, the intensive insulin therapy. Intensive insulin therapy in the form of actually the basal bolus therapy in stable patient, along with multiple corrections that can be given. And those patients who are critically ill, then you can use the insulin infusion. So at the end, actually, I will conclude my talk with this state. If I stand with 1 foot in bucket of ice water and 1 foot in bucket of boiling water, on an average, I am comfortable. Now, this is what said by Kelly Close, basically, who is the CEO of Close Concern, who said basically, based upon this, while treating diabetic patient who is critically ill, remember it is very important to control the blood glucose level. If blood glucose level is not on target, in hospitalized patients who have been hospitalized for short period or longer period, ICU mortality or mortality even in stable patient significantly goes high. With this, I will conclude. Thank you very much. I will be happy to answer if there is any question, because there was a lot of mathematics involved in my talk. Any question?
What should be the basis of control of glucose, whether it is weight of the patient or blood glucose level?
See,
Because initially it was proposed that the weight should be calculated on the basis of the weight, insulin doses should be given to control.
Agreed. To begin with, all of us are following the same pattern, and even I told you in step 2, So there are the different dosage that I mentioned. So based upon the weight only, we are starting the insulin, and then we are monitoring the patient, because these all patients, they are critically ill. They are having metabolic stress. Because of metabolic stress, blood glucose level has gone up. So there is a high degree of insulin resistance which has been created by counter-regulatory hormone. So no doubt, we start by using weight into, whatever dose that is suitable for that patient, and accordingly we go on monitoring the patient. The key is monitoring. You monitor the patient, and as long as actually blood glucose level is not coming in target, you have to increase the dose. Initially, you increase the dose, and as over the period of time, patient become dynamically stable, metabolically stable, then automatically these doses, they will come down.
In MPO patients, it is essential to give glucose. Requirement is 5 grams per hour. So we often forget that, and that lands the patient in starvation ketosis, which is very common but which remains undetected. That is one of the reasons of delayed recovery from ICU.
That's what I mentioned actually in catabolism. So that's the reason glucose insulin infusion is to be continued.
No, even when you are giving, otherwise also, any NPO patient must receive glucose, 5 grams per hour. That's the requirement.
We are in critical conditions. Balancing and going and on that note, that matters.
Yes.
Hypoglycemia versus hyperglycemia. And even hypoglycemia can be more dangerous in patients. And already it has been shown in the many studies that will increase the mortality. So that is the real challenge. As you told, definitely continuous infusion therapy, that is very important. But in any critical, because nutrition also matters, along with other therapies matters, and definitely keeping a good watch on the patient. Ultimately, that is the crux for outcome of any critically ill patients, and that vigilant intensity, any technology comes that is very important for the outcome. That watch on the glucose also is very important.
I would say that it was a very elaborate and very clear presentation, a beautiful presentation.
I request our chairpersons to kindly felicitate our speaker.
Not versus. No, Bosle felicitating us.
I request Dr. Jawad sir to kindly felicitate our chairperson. With this team, we move on to our next session. Thank you, madam. Our next session deals with a very practical challenge, that is steroid-induced hyperglycemia. I request Dr. Dilip Tombe sir and Dr. Sharad Bijani sir to kindly chair the session. Our speaker for the talk is Dr. Ajay Rote sir. Sir has got many professional roles. Sir is medical director and senior diabetologist. Sir has a leadership quality, and I request her to kindly. I request our chairperson to kindly introduce the talk.
Good afternoon. Our next session is on steroid-induced hyperglycemia. which is day-to-day in our practice. With widespread use of steroids in various clinical conditions, blood sugars rises and can significantly impact patient outcome if not managed proactively. Understanding the pattern of glucose elevation, appropriate insulin adjustments, and monitoring strategies is essential for safe and effective care. For this, we have today's expert speaker, respected Dr. Ajay Rotet sir. I request sir to begin the session. Thank you.
Thank you very much. First of all, would like to thank the organizers for inviting me as a faculty for this very interesting topic. So what I'll be doing is next 22 minutes, I'll be discussing on the topic of steroid-induced hyperglycemia management strategies. And at each of the point during my discussion, you will be getting some clinical pearls, as my intention is to make it more practical and oriented towards what is clinically significant and what matters most for all of us. So steroids have been mainstay of therapy for many of the diseases, especially respiratory disease. As you can see, 0.7% of the patients, admitted patients, use steroids. 40% of them use for respiratory problems. Inpatient is used for more than 10%. Most of them use for less than 5 days, but 22% use for more than 6 months. 4.3% patients use for more than 5 years. So starting from even an acute condition to chronic and lifelong condition, steroids have been used. So how do we manage the hyperglycemia? Why steroids cause hyperglycemia? So which are the patients at risk of developing hyperglycemia with steroids, with the use of steroids? Those who are already having diabetes, type 1 or type 2. People are on the verge of getting diabetes, the pre-diabetic patients, impaired glucose regulation, and people who previously developed hypoglycemia with steroid therapy. So these are the patients who are at risk of developing hypoglycemia when steroids are being used. So these are the commonly used steroids, as you know. So we are using hydrocortisone, and these are the equivalent doses at 20 milligrams of hydrocortisone, equivalent to 5 milligrams of prednisolone, 4 milligrams of methylprednisolone, 0.75 milligram of dexamethasone, and 0.75 milligram of betamethasone. And you can see at the duration of action, this is very important to time which insulin is to be given at what time. Then and then only we can prevent or we can control the hypoglycemia aspect. Adrenal glands normally produce cortisol that is equivalent to around 7.5 milligrams of prednisolone. Any dose higher than this 7.5 milligram will lead to hypoglycemia. So doses more than 7.5 for more than 2 weeks, then they will cause adrenal suppression. So this is something very important. Normally we consider that steroids are used safe up to 2 to 3 weeks. After that, it is recommended that if you discontinue, it should be tapered down. Too rapid tapering or withdrawal will lead to hypoadrenalism demonstrated by recurrent hypoglycemia, hypotension, hyponatremia, and hyperkalemia. How do typically steroids work? They acutely increase hepatic glucose production. So this is something very important, that they are going to increase hepatic glucose production, and there are some complex effects on beta cell function that may reduce insulin production also. So on one hand, glucose is produced excessively. On the other hand, insulin is secreted in a less quantity. They promote the visceral adipose tissue deposition and enhance lipolysis, and they alter the level of adipose tissue derived hormones and cytokines. So glucose inhibition has been the mainstay of steroid functioning. It starts very early after steroid injection. In previously well-controlled diabetic patients, it can lead to postprandial hyperglycemia. So practically, they are increasing the insulin resistance. So typically, they will cause a rise in postprandial sugar levels. Hyperglycemia may be transient rise of blood glucose levels, or it can be a very severe form. And the best predictors of glucocorticoid-induced diabetes are family history of diabetes, increasing age, and the dose of glucocorticoid. That we should remember. Now, these are some important things. So steroid-induced hyperglycemia is a new onset hyperglycemia or worsening of pre-existing diabetes following glucocorticoid initiation. incidence of steroid-induced hyperglycemia is quite significant. It's 12 to 57%. It varies widely depending on the use of steroid, duration, and patient risk factors. What is the clinical significance? Why do we want to focus on this steroid-induced hyperglycemia problem? Because there is an increased risk of infection, impaired wound healing, prolonged hospitalization, and increased mortality. So steroid-induced hyperglycemia is a clinically very significant aspect. It is not only a nuisance, it's a major driver of adverse outcomes in hospitalized as well as like OPD patients. So in both of those cases, this is very essential to understand. This is called the science of spike. So we know that after steroid use, the glucose spikes. So there is this I had already discussed. So there is increased insulin resistance, that is primary insulin resistance. Then there is increased hepatic glucose production, impaired pancreatic beta cell function, and this is something called as a temporal glucose profile, which is critical for insulin selection. So 4 to 8 hours post-steroid dose, the peak is afternoon or evening for morning steroid dose, aligns with the steroid pharmacokinetics, and duration is hyperglycemia persists until steroid effect wanes. So whenever you give a morning dose of steroid, afternoon or evening spike is likely to have. What's the clinical implication? The timing and pattern of hyperglycemia must match the insulin regime. A morning dose of prednisolone requires afternoon or evening dose of insulin coverage, and this principle guides the choice between NPH, that is intermittent acting, and long acting insulin. So this is very essential. It's a very critical aspect. Which insulin are we giving to the patients? This we already seen that in the relative potency of hydrocortisone is low, prednisolone is medium, methylprednisolone is again medium, dexamethasone the relative potency is high, duration of action is longer, and peak hyperglycemia is sustained for more than 24 hours. That's why if you can see the clinical implications for insulin, so which steroid is used and what insulin you are using. So if it is hydrocortisone, you can use rapid acting insulin, consider short acting coverage only if high dosage. So if hydrocortisone is given, that there is a postprandial peak. So a short-acting insulin or short-acting insulin analog can be useful in these cases. If it is prednisolone or methylprednisolone, NPH or intermittent-acting insulin would be useful because that matches with the profile of steroid action. And if it is dexamethasone, it is better to give glargine or degludec basal insulin apart from, if required, short-acting insulin. So these patients would require. So this is how which type of insulin you want to give for which type of steroid. That's very essential. What is the takeaway from this? That dexamethasone and high dose of prednisolone carry the highest and most sustained hyperglycemia risk, requiring a 24-hour basal insulin coverage. So whenever a patient is on dexa or high dose methylprednisolone, then they would require a 24-hour coverage. That is very essential. So insulin is obviously recommended as a drug of choice for the treatment of glucocorticoid-induced hyperglycemia. Prandial insulin should minimize the effect of postprandial rise in glucose. So it was studied that steroids act on insulin receptors and increase the insulin resistance. That is the reason of postprandial spike after a steroid dose. So that can be taken care by the short-acting insulin or a short-acting insulin analog. So patients receiving high-dose intravenous steroids and intravenous insulin infusion may be appropriate. So as my previous speaker has mentioned, insulin infusion is one of the best ways to control hyperglycemia. Also, because in intensive care setup, many patients would be on intravenous steroids as well. So for them, intravenous insulin infusion would be better way. However, how much insulin should be given in the insulin naive patient? The patient who has not received insulin in their lifetime, how much insulin is to be given? That's a question. What about dose increases in people already on insulin, and should it be given or IV or SC, that is intravenous or subcutaneous? But that will depend upon the type of the patient, the situation, the criticality of the patient. So IV infusion allows appropriate tapering of insulin infusion rates. Glycemic control is not compromised. So in any case, if we can give IV infusion insulin, that is the best possible for an admitted patient. But for an OPD patient who is admitted in a ward or this kind of thing, we can give subcutaneous insulin. So, sir, IV insulin is not the answer for all, but maybe if the blood glucose is consistently above, so we need a basal bolus regime. No work has been done to compare human with analog insulin in this field. So, especially for steroid-induced hyperglycemia, there is no comparative study between a human insulin and an analog insulin. However, logically speaking, analog insulins would be better to control the postprandial spikes. Which insulin? So intermittent acting human basal insulin once a day, gradually up titration. Analog basal insulin is hyperglycemia throughout the day, and if there are early morning hypos also, then we should think of what type of insulin are we giving. Risk of hyperglycemia versus hypoglycemia, there is a very fine balance that we have to maintain. Duration of steroid therapy, pre-existing diabetes and comorbidities that we should consider. It should not be a standalone kind of thing. So even when a patient is receiving steroid, the patient's condition, clinical condition, needing other medications, those also have to be considered while giving the insulin therapy. So what is the threshold for action? The target glucose range is 140 to 180 mg/cent. So at all given moments, we have to ensure that glucose levels are maintained between 140 to 180. If blood glucose is more than 180, on 2 or more readings, insulin has to be started, irrespective whether the patient is diabetic or not. Patient is admitted, sugar level is more than 182 occasions, we have to start with insulin. If it is more than 250, even a single reading of 250 or more, we require to start insulin. So that's a clear-cut guideline. So why insulin is first line? All you know that efficacy, tolerability, safety, and there are practically no contraindications. We can just titrate the dose. So insulin is the preferred choice for steroid-induced hyperglycemia. This is something what is called as matching insulin to steroid, that is NPH strategy for intermittent acting insulin. So those steroids which I had shown you in the table, who have got shorter or medium or intermediate duration of action, NPH insulin can be very well utilized. It is still available, it's quite good insulin, and we can use the core principle is pharmacokinetic matching. So this NPH insulin matches the pharmacokinetics of the steroids which we are using. That's why NPH is recommended. This is called as NPH strategy. Starting dose calculation, it could be 0.1 to 0.2 units per kg body weight for NPH, and accordingly it can be titrated. Administration of NPH can be done. Morning steroid dose, afternoon or evening hyperglycemia, so NPH peaks at the right time. So those steroids when we use, which have got a post-meal afternoon or evening spike, then NPH insulin can be very safely used. And there are certain terms which are used like augmentation, replacement, as far as insulin therapy is considered. Now, what are the advanced strategies of use of insulin for steroid-induced hyperglycemia? As you can see, you can use long-acting insulin, that is glargine or degludec. This is ideal for dexamethasone or continuous steroid infusion. So, if patient is on continuous steroid infusion, ideal way is to start insulin infusion, but otherwise we can use the long-acting basal insulin in the form of glargine or degludec. So, the dose that is to be started is 0.1 to 0.2 unit per kg body weight. If the patient is already having diabetes or the patient is already on insulin, then a basal bolus therapy would be ideal for these patients. So in that pre-existing type 1, type 2 patients or very high hyperglycemia, we need to give a basal bolus coverage. And we have seen in our earlier lecture how to calculate the total daily dose of the insulin and then divide in basal and bolus to have adequate coverage. So choosing among the long-acting infusions of sustained hyperglycemia, basal bolus is an ideal way to control steroid-induced hyperglycemia. What is the titration-based and evidence-based starting dose and titration protocol? So if the steroid intensity is low dose, that is less than 20 mg of prednisolone per day, then starting insulin dose would be 0.1 unit per kg body weight per day, and insulin type would be NPH or basal insulin. If it is medium dose, that is 20 to 40 mg, it is 0.2. If it is high dose, that is more than 40, 0.3 units per kg body weight per day, that is to be given. And every time we have to split the total insulin dose between a basal and bolus has to be again divided into 3 components depending on the food intake. Titration protocols and monitoring are to be followed in the ICU as hypoglycemia risk. So this is something called as a taper trap. So when you taper the dose of steroids and if you continue the same dose of insulin as you have initiated, then what is called as a taper trap, you get trapped and the insulin patient is likely to land up in hypoglycemia, which we don't want to happen. So this is very important to avoid this. This is a hypoglycemia risk. So as the steroid dose is reduced, the insulin requirement drops rapidly and unpredictably. Now remember this, that once the steroid dose is reduced and effect is waning off, suddenly glucose may come down and you cannot predict at what time, in what number the glucose will come down. So there is always a risk of hypoglycemia which we should consider. What is the solution to this taper trap? The solution is to have proactive insulin reduction strategy. So core principle is to reduce insulin before hypoglycemia occurs. So we should anticipate that this patient may land up in hypoglycemia once your steroid effect is waning off or steroid dose is coming down. So accordingly, to put it in a simple words, when the steroid dose is cut down by 50%, insulin dose should be cut down by 50%. If the steroid dose is cut down by 25%, reduce the total insulin dose by 25%. So it's again a matching kind of thing. I have put it very simply, but this has been recommended by many guidelines. But if we do it proactively, the risk of hypoglycemia will come down. The taper trap, which I was mentioning, is preventable with proactive planning, and we should treat steroid tapering as a dynamic process requiring parallel reduction in insulin dosage. So this we have already seen. There are monitoring protocols and discontinuation, when to discontinue insulin after discontinuing the steroids. Now the steroid-induced hyperglycemia, if you see in a non-diabetic patients, there are certain unique considerations. We have seen that patient is already diabetic, then you are giving insulin, you are monitoring, and protocols are being followed. But the unique challenge in these cases, that remember that a non-diabetic patient is possibly more sensitive to insulin dose. So while giving insulin to a non-diabetic patient, probably you have to give a justified way. The dosage of insulin has to be titrated very nicely. So it is better to avoid long-acting insulin, prefer NPH or intermittent-acting insulin, and because it's a predictable 6 to hours peak. On the other hand, NPH is intraday variation is more, so there is always more risk of unpredictable glucose levels. But still, it is recommended to avoid long-acting insulin. So this is how we mitigate the risk, treating the steroid effect, not the permanent diabetes. We are just focusing on what the steroids are causing havoc to glucose level, so that adequate care is taken in all these patients. So to summarize my discussion, mechanism we have seen insulin resistance with afternoon and evening peak, which is very common. This is due to increased insulin resistance with the dose of steroid, and point two is steroid specific strategies match the insulin to the steroid. So this is something very important. When starting and even when discontinuing, it is better to start match the pharmacodynamics and pharmacokinetics of insulin with the steroid. Then dosing principle, start low and titrate aggressively. We should start low just to test what is the sensitivity, insulin sensitivity of that particular patient, but titration has to be done aggressively so that there is no hyperglycemia. Safety first, so never stop insulin abruptly. So this is something which is called as a proactive insulin approach. It is called as a BBC, as basal bolus and correctional. So sudden stoppage of insulin is also not good, because that may land up in hyperglycemia. It should be very scheduled basal and intermittent insulin and correction dose insulin. So this is what is called as a proactive insulin strategy, not a reactive insulin strategy. Taper trap we have seen, this is again a proactive insulin reduction. We should anticipate that this patient will land up in hypoglycemia. Accordingly, the dose of insulin has to be tapered down. And in non-diabetic patients, temporary coverage is the goal. So that will depend upon the glucose level, that will depend upon the insulin sensitivity of that patient, and for how long the steroid therapy would be continued. So this we have discussed. These are the 5 essential clinical words for steroid-induced hypoglycemia. Thank you very much. If there are any questions, we can discuss.
Thank you, sir, for explaining topic in detail. So basically, there are 3 scenarios where routinely we use steroid. First is some autoimmune condition or connective tissue disorders or some spine injury. We have to give methylprednisolone 1 gram for 3 to 5 days. Second scenario is exacerbation of bronchial asthma or COPD, where we have to use hydrocortisone 100 mg 8 hourly. And third scenario is according to new guidelines in septic shock, which is refractory. We have to use hydrocortisone infusion 200 mg. We have to give over 24 to 72 hours. So, as per your detailed discussion, methylprednisolone causes prolonged hyperglycemia, as well as dexamethasone also, when we use in HLS, it can also lead to the prolonged hyperglycemia. So, if methylprednisolone we are using for 3 to 5 days bolus, and we want to taper off insulin, so how we should approach in that case? In case of autoimmune disorder or spine injuries.
So you are talking, especially maybe on day 2 or day 3, there will be highest hyperglycemia possibly. So on that day, the dose of short-acting insulin or insulin analog would be probably highest. And then day 4 and day 5, we have to taper it down. And roughly, the roughly arbitrary figure is reduction or increment in the insulin dose to the tune of 10 to 15% as compared to the earlier dose. That has been mentioned in many trials, many guidelines.
Okay, sir. Thank you, sir.
Anything about, I mean, the list of steroids was not having deflazacort.
Deflazacort I have not mentioned because, considering the impact on hyperglycemia with deflazacort is minimal. In most of the studies, and deflazacort is usually not utilized in intensive care settings. Deflazacort is used in OPD-based setting, that is one. Second, it is used in skin conditions as well as in bronchial asthma and respiratory conditions. But even in studies or even in our practical clinical scenario, we haven't found a great derangement of glucose levels with the use of deflazacort. So it was not considered. And see, there would be many more steroids which are available and which will come also. But then we have to compare as a unit with dexamethasone or methylprednisolone. As of now, methylprednisolone would be one of the steroids which has got the longest impact, highest impact on prolonged impact on hypoglycemia. So we have to compare in a unit by unit this thing with the new steroid that is coming up.
I request our chairpersons to kindly felicitate our speaker.
Bookie certificate. Do.
Thank you very much, sir. I request Dr. Shafi sir to kindly felicitate our chairperson. Thank you, sir. Moving to our next session, I believe every one of us is getting hypoglycemic. So lunch is being arranged at the restaurant. After this session, we'll conduct the vote of thanks, and after that we'll proceed for lunch at the
Hypoglycemia
So our next talk is on management of hypoglycemia. I request Dr. Amit Nagate sir and Dr. Jawad Hashmi sir, professor at PSM Department, Indian Institute of Medical Science and Research, to kindly take the chair for the session.
Now I call upon our speaker, Dr. Yogesh Rakesh sir, who is Professor of Medicine at Indian Institute of Medical Science and Research. Sir is ICU in charge at the Indian Institute of Medical Science and Research. Sir is also currently Secretary of IMA Chhatrapati Sambhajinagar for delivering the talk. Sir is UG PG teacher, and sir has organized many conferences and CMEs, and he is an aggregated speaker and the chairman of our Gaon Chale project. I request sir to kindly take the dais.
The slide is old one. Last year. We'll just go with the. First of all, thank you organizers, and probably this is this very important Insulin Summit has been organized by our own institute, Elite Academy, Dr. Shafi sir, and all the organizing team along with the Diabetic Association. And to have such academic programs frequently, I have been seeing that Dr. Shafi has been organizing, and these are very important, and many of the we come to know, and there is an exchange of thoughts, exchange of ideas, that is very important. And already all the diabetic experts in our city, they have covered almost each and every aspect of the related to the diabetes management in perspective to various patient care levels. And I have been given the task of management of hypoglycemia. Probably I work in the ICU, and probably that is why the organizers have given one of the important emergency that we can see in the ICU or in the hospital setting. This complete schedule you have followed. Once again, I thank you organizers. The agenda would be introduction, and then there is an important concept of hypoglycemia awareness. Then consequences of the hypoglycemia that we'll be discussing, magnitude of hypoglycemia in insulin-treated diabetes, then hypoglycemia risk in different insulin schedules, what is the current scenario that we have, that we'll be discussing here. Then what is hypoglycemia? Low plasma glucose level causing neuroglycopenic and neurogenic autonomic symptoms, which are relieved on raising the plasma glucose level. The clinical definition of hypoglycemia, if it is a mild, it can be self-treated, and if it is severe, requiring the help for recovery. Then what are the levels of hypoglycemia that we see? This has been less than 70 milligram percent, then moderate, that is 54 milligram percent, and below that, when particularly the neuroglycopenic symptoms do occur. Hypoglycemia is inconsistently reported and defined, as we can see that only the tip of iceberg patients, those are reported, and there is a many cases goes undetected, and that's why it is very important to analyze it, very important to report it, and whenever it is severe cases of hypoglycemia, then emergency admissions may be needed, and that need to be treated to prevent the consequences of hypoglycemia or end stage damage to the various systems or the cerebral damage also. And hypoglycemia episodes often go unrecognized, that we discussed. Hypoglycemia confirmed by CGMS is often unrecognized, because many of the times that mild level of hypoglycemia, like around the 70 milligram percent, patient may not have those autonomic symptoms, and that nowadays we are following this continuous glucose monitoring, and we can have those levels, and that's why at one end, that continuous glucose monitoring will be helping us out to prevent the hypoglycemia, or management of the hypoglycemia. But other way, it is only the tip of iceberg cases, those we are detecting. 63% of the patients with type 1 diabetes and 47% of the with the type 2 diabetes. As we have seen that type 1 diabetes, particularly those who are on the insulin or insulin therapy, they are prone for development of the hypoglycemia. And type 2 diabetes, we will be seeing in the subsequent slides also, whenever like initially they are on the oral hypoglycemic drugs, and later on when they are added with the insulin therapy or something like that, that is the crucial phase where they are likely to develop these hypoglycemic therapies. And in addition to that, as your diabetes progresses or duration of the diabetes progresses, then usually you can have these more hypoglycemic episodes, and you have to be very much vigilant at this level. Hypoglycemic events occur frequently with the type 1 diabetes that we have seen. Type 2 diabetes, the hypoglycemic events, these are less, but compared to the volume of the type 2 diabetes, the number of hypoglycemic patients, those may be higher, because the type 2 diabetes patients, the number is very high. Adverse event diagnosis in the endocrine therapy. As we can see that 94.7% of all endocrine emergency hospitalization are due to hypoglycemia. When you see the emergency admissions with different endocrine emergencies, we have seen that this is the important thing that where hypoglycemia has led to the emergency admission in the patient. And ER visits and hospitalization due to adverse drug events categorized by the therapy category, we can see that the hematologic the drugs, like this has been plotted in the study, or this that hematological agents, they count the number 1, but endocrine agents, like we can see the third graph, where like these insulin therapy or these anti-diabetic drugs which has led to hypoglycemia, that counts the important emergency admissions, or the patient comes to the emergency room. Medications most commonly associated with emergency hospitalization in patients more than 65 years. Again, you can see those two blue, these insulin and OADs. These basically, you can see that they count a large number of emergency admissions to the things. Here in these presentations, mainly the thing is that the prevention of hypoglycemia, what strategies we can do, that we'll be discussing, and that will be the important. The management of the hypoglycemia in at this stage, that will be common or emergency, you will be giving the glucose, dextrose, that will be there. But prevention will be always, and the strategies which will be adopting, that will be the very important to prevent, and we should be able to prevent, and which are the scenarios where particularly the hypoglycemia can happen, that we have to understand. And these insulin and OADs, we have seen that this is the important thing, that emergency hospitalization occur with these drugs. Higher rate of severe hyperglycemia in intensive glycemic. Various trials have found that whenever the intensive therapy is there, the insulin is added basically, then those have been found to have the higher incidences of the hypoglycemia. All these trials which were carried out, all these studies which were carried out, you can see that intensive therapy, those dark blue thing, that is the increased incidence of the hypoglycemia, you can see that. And that's why always it is important, the highlight of this presentation, that will be there. You have to know that particularly when your patients is likely to develop the hypoglycemia, and when you have to be vigilant for that. Adverse outcome among patients with type 2 diabetes experiencing severe hypoglycemia. You can see that with the time of the duration of the diabetes increases, definitely the hypoglycemia awareness also, and the hypoglycemia incidences, we have seen that they increase. And various causes of death with the duration that has been found, and that has been led to the mortality and all those things. Now, one of the important aspect of hypoglycemia awareness that one has to understand, impaired awareness of hypoglycemia. Initially, the physiological, what we have studied like in the presentations also, like what basal bolus insulins we are following, that is again you have to reach to the physiology of the patients. And initially, whenever hypoglycemia occurs, whenever 70 or moderate or even severe hypoglycemia occurs, initial steps will be again your adrenergic response, again your epinephrine response, all the stress hormones they come into play, and like they make a person aware of the things that like you now the hypoglycemia would be there, and maybe they know all this type 2 diabetes, even type 2 diabetes patients who are on the insulin therapy or OADs, they will know that I am likely to have the hypoglycemia, and most of the times they do take the glucose, or they do have the biscuits in their pockets, and they do take and they analyze this. But what happens over the times, this autonomic failure, even your hypothalamus, your brain gets accustomed, the homeostasis is disturbs that way that they are not able to judge these autonomic symptoms, and their awareness of the hypoglycemia that matters, and they are not able to judge these symptoms, and probably they land up in the emergencies, and they land up to the emergency department, and then you need the treatment. Impaired awareness of the glucose, as we have seen that this glucagon, adrenaline, this plays an important role. Autonomic glycopenic symptoms, neuroglycopenic symptoms, they do happen, and cognitive dysfunction that happens at maybe sugar more than 50 mg%, that way. The glycemic thresholds are modified in impaired awareness of the hypoglycemia. That we have seen that your homeostasis is completely disturbed, and that make you you are not aware of the hypoglycemia. The patients and they land up in the emergency. Then impaired awareness of the hypoglycemia naturally history, as we have seen that as the duration of, again many things will be similar at the duration of the diabetes, more is the duration of the diabetes, then definitely those changes or accustomed homeostasis that will be happening, and the patients they are not aware of these hypoglycemia episodes, and that will be the natural history of your diabetes, and that leads to again this impaired awareness of the hypoglycemia. Then clinical history from patient, awareness of the hypoglycemia and clinical assessment, history from observers, especially relatives, blood glucose monitoring data, look for frequent asymptomatic biochemical hypoglycemia, validated scoring systems may be needed. Then consequences of hypoglycemia, as we have seen that acute symptoms, these are very important: cognitive impairment, then mood change, work performance, then social activities, sports, morbidity in acute events. Long terms, reduced quality of life. We can see that fear, because of the fear of hypoglycemia, there can be under control of the sugar that can happen, and we can have the reduced level of insulin or drugs we will be giving. Then weight gain can happen because of that. Then there can be the problem for the employment. Then worsening of diabetic and vascular complications that can happen because of the fear of the hypoglycemia. Then morbidity of the hypoglycemia and diabetes, as we see that, which are the there can be coma because of the severe hypoglycemia. Then seizures can be there, cognitive dysfunction, psychological effects can be there. Then musculoskeletal with the hypoglycemia, with falls, accidents, fractures can happen, dislocations can happen, driving mishap can happen. Then cardiovascular, that is the important thing, like cardiovascular things and your diabetes that go hand in hand. There can be myocardial ischemia, cardiac arrhythmias. With all this autonomic increase of autonomic drive, there can be arrhythmia in that hypoglycemia episode, and then you have to have knowledge of this and that emergency transport to that emergency unit and managing those along with your hypoglycemia management, that will come into the picture. And really all these can increase the mortality and morbidity of the patient also. Then severe hypoglycemia is major predictor of cardiovascular death. This is one of the important slide. We can see that hypoglycemia itself, like the hazard ratio, and that is very high with hypoglycemia itself. And you can see that HbA1c it is 1.21, then HDL again it is a 0.69, and age it is 2.09, previous cardiovascular event it is 3.12. Like you can see that with hypoglycemia and age and with previous cardiovascular events, the hazard ratio is more. And even if the HbA1c hazard ratio is less, that's why this hypoglycemia is very important whenever you practice a diabetology practice, or whether you are in the practice of critical care specialty. Then you have to know that this hypoglycemia that can have the burden on the patient, that can have the increased morbidity as well as mortality for the patient. And this we have seen that sympathoadrenal activation is there, hemodynamic effects can happen when the hypoglycemia is there. Definitely this patient can go in hypotension, then shock can be there. Simultaneously you will need to manage the arrhythmias also along with that hypoglycemia episode that you will be managing. Consequences of hypoglycemia, third part, all these things, because this is a emergency situation where you manage hands in hand with the hypoglycemia, giving the dextrose. Along with that, your patient can land up in any of these things. That convergence you will need to manage at that time. Then cardiac events, as we discussed, that various arrhythmias that you might need to manage simultaneously. Then with fear that your patient may be taking later on in the life lesser or underdosing can be there with the oral hypoglycemic drugs, or then that can lead to the weight gain, or that can lead to the lesser control of the glucose in patient's life. Then quality of life can be different with fear of the hypoglycemia. Then magnitude of the hypoglycemia in insulin treated diabetes. Data on frequency of the hypoglycemia are probably underreported. We have seen that only the very less cases they are reported of the hypoglycemia. So that's why this reporting would be very important, or for that scoring systems would be important, or you will have to plan scoring system. You will have to counsel the patient's relative that way. With such symptoms, that is a part of your history itself. Like whenever you are treating the diabetic patients, then you have to tell that when you are starting the insulin therapy, when you add on the insulin therapy on the OHA also, in the type 2 diabetes also, then that counseling matters, that communication matters with the patient's relatives, patient's spouse, so that more and more episodes you can detect. In fact, I would say that will help you preventing the episode itself, or you will be going in that direction. Now the continuous glucose monitoring system have come, but that may not be feasible in Indian scenario always. Then the recognizing the symptoms, that matters a lot. Then severe hypoglycemia is more frequent in type 1 diabetes than type 2 diabetes. The sky blue color is the type 1 diabetes, we can see that, and the dark blue is the type 2 diabetes. In addition to that, you can see the diabetes duration less than 5 years and diabetes duration more than 15 years. Here the star marks, you can see that when the diabetes duration is more, then definitely the severe hypoglycemia is more frequent in that aspect. And only that as it is a epidemiological data, you have to remember that type 2 diabetes burden is more worldwide. So number of hypoglycemia episodes in type 2, absolute number will be more in type 2 diabetes. But when you see the percentage wise, then definitely the type 1 diabetes that will be counting more severe hypoglycemia episode. However, it is the same slide. However, hypoglycemia is more frequent in type 2 diabetes becomes insulin deficient. Again, this point we have discussed. Whenever your patient will be going from oral hypoglycemic therapy to insulin, you will be going on adding insulin, then definitely you have to be vigilant that such episode can come up and you might need to be prepared for that emergency, and you will be counseling your patient that way any of the symptoms that happen, because in the initial period your autonomic system will be functioning. It is over the period that failure of autonomic failure or hypoglycemia unawareness that we have discussed, that happens over the period of time as your diabetes duration increases. Increasing hypoglycemia when insulin is added to the therapy, that we have seen that you have to be particularly vigilant at that time. Then prevalence of severe hypoglycemia in type 2 diabetes increases with longer duration of therapy, that we have seen that when here you can see that duration of the insulin more than 10 years, significantly higher number of patients, they will be coming with the hypoglycemia episodes, and you have to be vigilant for this. Then incidence of severe hypoglycemia in insulin treated type 2 diabetes patient is higher than previously thought, as many of the studies they have reported similarly, like severe in type 2 diabetes status, usually percentage wise it is approximately 30 like 1/3 of the patients as compared to the type 1 diabetes. Then as you know that the oral, few of the slides they are not included, but the older oral hypoglycemic drugs as compared to the newer OHs, they have the lesser incidences of the hypoglycemia, and similarly the newer analogs, this is what we have been discussing, that the bolus newer analogs, they will be having a very physiological aspects of their action is physiological. That's why hypoglycemia episodes with these newer analogs, that will be less, and you can wherever your patient is affordability is there, your patient is going into the frequent hypoglycemia episodes, then you can go on changing the human insulin to the newer analogs. And definitely here in this slide you can see that the time of duration biphasic human insulin, frequency of self-reported hypoglycemia, the rate is measured. The CGMS detected events, you can see that that is early morning it is there, and as compared to this self-reported hypoglycemia, when the CGMS is not there, that also you can see that in the daytime the patient will be detecting, because these night-time events that will be detected or they may go undetected when CGMS is applied to the patients. That matters, that importance of the glucose monitoring system. But sometimes that may not be clinically important. So in toto, that tip of iceberg, but you have to see that, and whenever it comes to formulating the trials or that way, definitely which figure is to be taken, that is still that will be the important thing, that either 70 mg% or 54 mg%. So you will have to devise the trials that way, and definitely that will depend on that. Then biphasic insulin aspart versus biphasic human insulin, a CGMS comparison in type 2 diabetes mellitus. These are the things that the biphasic, you can see that aspart, the blue lines are that, and the brown is human insulin, and you can see that the early morning after the 12 o'clock, the aspart hypoglycemia events are happening. But when you compare through the hourly incidence of the analogs, that is more or less the less hypoglycemia things they are happening. But when you see that human insulin is there, then definitely early morning, you can see that 4 a.m. to 7 a.m. so that human insulin, that will be leading to the hypoglycemia. All these physiological things, you have to be aware of the things. You may you may have the continuous glucose monitoring, or you will have to monitor clinically. That matters that way, and definitely using those analogs or newer drugs, that will be of use there to prevent these hypoglycemia episodes, or whenever it will be a individualized therapy rather than you will be applying same things. That clinical judgment you will have to take in all these patients. And similarly, you can see that meta-analysis of hypoglycemic event rates with biphasic insulin aspart versus biphasic human insulin. You can see the significance here. The figures, like you can see, overall it is same, but the timing of hypoglycemia, that matters with this, and the treatment more or less, the your newer analogs, they will be very much important for treatment of these hypoglycemia episodes. And to summarize with this, the hypoglycemia is inconsistently reported. That is one important thing. Impaired awareness of hypoglycemia contributes to adverse outcomes. Hypoglycemia more frequent with disease progression. Then nocturnal and major hypoglycemia less common with biphasic insulin as compared to the biphasic human insulin. Means newer analogs you can use. You have to clinical judgment is important. Every case is individualized. For that, either you take help of the continuous glucose monitoring, or you take that is the important thing, and or clinical judgment, or every history that will matter, so that counseling of the patient, communication with the patient's relative, that is going to matter to prevent this episode, rather than when they come to emergency, then definitely giving the dextrose, then analyzing whether it is coming up. That will be the last step to treatment of that. But preventing the hypoglycemia, that will be the very important, and to have a good history with that, that will be the very important thing in preventing in these hypoglycemia episodes. And use of the newer analogs will be very important. Thank you, organizers, once again. And these all the topics are very important in the critical care aspects also, analyzing the hypoglycemia, and hyperglycemia was also already discussed. And newer and newer trials, newer and newer drugs, now inhalational insulins will be coming there. But that judgment, ultimately, clinician has to have his judgment for treatment of all these cases. Thank you.
Thank you very much, sir, for your nice and lucid presentation. It's looking like more than hyperglycemia, hypoglycemia is more important because of the consequence and other things that has to be checked. Thank you very much, sir.
I request our chairpersons to kindly felicitate our speaker. I request Dr. Shafi sir to kindly felicitate our chairperson. Yes, sir. I request Dr. Shafi sir to kindly take the dais for vote of thanks.
So on behalf of Elite Education and Welfare Society, I am very thankful to all those who have come and attended, presented, acted as a chairperson, organized all people. I am very thankful Dr. Bhosle sir that this was his initiative, that he wanted to have one CME with Elite Education Academy. So we are very thankful to sir, and we hope that in future also we will have more programs like this. So it was the sir whose idea today it had worked. And the World Diabetes Day is on 14th November, so we thought that why not to take a topic which is related to the diabetes. So we are very thankful to the sir. We are thankful to our college that they allow us to conduct the activities in Aurangabad city. And the more important thing is that this CPD was approved by Maharashtra Medical Council and 2 points were granted. So each speaker will get 1 point and delegates will get 2 points, and certificates will be given to you, e-certificate. Within 3 days, we'll post it in the group. So once again, I thank all of you and I request all of you to please join for the lunch. Thank you.
Certificate.